Good evening and welcome to the Foreign Correspondents Club in Bangkok. For those of you who've never been here before, this is the largest and oldest press club in Southeast Asia. It's one of the three top press clubs in Asia as a whole. We do programs every week under normal circumstances, and normally we attempt to fill the room with as many people as possible. So this is a very unique evening in which everybody here is actually socially distanced. We have the floor laid out classroom style, so it's not like anything we've ever done before. Anyway, before I go to the program, I'm going to show you something slightly different, which is a piece of public service broadcasting from the Ministry of Public Health, and it's their Department of Mental Health that has put this together. And I think it'll give you an idea straight off that things in Thailand are sometimes done a little bit differently. Julian.
หยิบอะไรล่ะโอ้โหโอ้โหดาบนี่มันดาบไลท์เซเบอร์นี่ละเมอเหรอ
เป็นอะไรอ่ะ
ช้อนกลาง
น่าอร่อยจัง
ใช้ช้อนกลางส่วนตัวทุกวันเพราะฉันคือฮีโร่
So as you can see, that was a public service message, and the Department of Public Health, Mental Health, has been putting these out with different endings so that, you know, there is advice on washing hands and everything else to do with keeping COVID at bay. The reason for the program tonight is the medical situation in Thailand, which is so much better than was expected. The program is not going to cover the economic fallout, what's happened to the tourism industry, what's happened to aviation, manufacturing, because these are massive topics. I mean, we just accept that there's been huge damage. We're having a look specifically tonight about what's happened in medical terms. So Thailand, having been one of the countries that there was great concern about initially as after the virus emerged from China, has so far had 58 deaths. It's had 3,119 confirmed cases. Almost all those people have now recovered, and there are 47 still being treated. It's difficult to give a sense of scale, but today there was a news report that the USS Theodore Roosevelt, an aircraft carrier, has got 60% antibody positive sailors on board. An aircraft carrier is a massive thing, so that's around 3,000 people. So one US aircraft carrier has had as many confirmed cases or as many suspected cases as the whole of Thailand has proved so far. A friend was doing some sums on comparing Thailand to the UK and worked out that Thailand's 58 deaths roughly equates to 2 hours of deaths in the UK. So if you work it out, it's just staggering. So the UK has had 40,500. France has had nearly 30,000. France is almost identical to Thailand in terms of population and landmass. Great similarities. So Walden Bellow, who's usually a great critic of Thailand, wrote recently, in Asia, if we are to believe the numbers, Thailand has done much better than Japan or South Korea, which are often written about as success stories. Anyway, on that note, we've got in the club tonight, under these very unusual circumstances, an extremely distinguished panel, and we have basically the two top spokespeople for COVID-19 from the health authorities. So we have Dr. Tawasin Visanyotin, who's the spokesman of the Ministry of Public Health and of the Center for COVID-19 Situation Administration, CCAS. We have Dr. Thanarak Plipat, who's the Deputy Director General of Communicable Diseases, Ministry of Public Health. Dr. Thanarak has actually addressed the club twice now, once remotely, so he's getting used to us. We have Craig Griffin, who's the Chief Insight Officer, Fuel Research and Consulting, and he's the Thailand representative of ISAMAR, which is a global association of the market research community based in the Netherlands. We have Matthew Tostevin, who is the Southeast Asia editor for Reuters. So Matthew is responsible for all the bureaus in Southeast Asia. And in Australia, there he is. Are you in Canberra or Sydney?
Canberra.
Canberra. Is James Wise, who's the former Australian ambassador to Thailand, has a long experience in the country, and the author of a book, Thailand History, Law and Rule of Law and Politics. I can't remember the name of the book, sorry. Anyway, it's a memorable book.
Close enough.
Thank you. It's 10 o'clock in Australia, so we hope you don't nod off.
It's 10 o'clock and 4 degrees.
We're going to kick off with Craig Griffin, because basically Craig specialises in numbers and data, and we want to get a feeling for how good the numbers are on Thailand and build from that. So Craig, what are we dealing with? Is this credible?
Okay, so I think the short answer that I have to that question is yes, I personally believe in the data. But I do think we have to be a little bit careful how we use the data and the comparisons that we make, particularly when we're comparing. I mean, what people tend to do is compare data across countries, and we have to be a little bit careful doing that. So I'm just going to expand on those points. But first of all, I completely get some of the skepticism that we seem to be hearing, the sort of distrust in the numbers. We don't have to go back that long to a stage when Thailand was actually had the second highest number of cases in the world. I certainly remember that time well. And now we're at a point where we've had 2 weeks without local transmission. So that's a huge turnaround, and I think something to be really proud of. But of course, that's only if we trust in the numbers. And as I say, I personally do. There's also a huge public interest, in this epidemic in the numbers, because we're all using the numbers in one way or another to assess the risk that we have, either personally the risk, to spreading to our families or for our businesses. And of course, the numbers are also used for the justifications for taking the interventions and the lockdown measures. So the numbers are very important, and we need to trust them. And there's two arguments that I hear regularly. One is a very sort of general sense of, these numbers can't be right. I don't trust the numbers. I think there's something being hidden here. And then there's a more specific argument which I hear a lot, which is, no, we can't really believe the numbers because Thailand's not doing enough testing. So I just want to kind of address both of those points fairly quickly. First of all, in terms of, we can't trust the numbers generally, at the moment we've got 58 recorded deaths in Thailand. If the epidemic was such in Thailand that it was serious as it is, as we see in a lot of European countries and the US, we'd be talking about thousands of deaths. And if we were talking about thousands of deaths, then obviously there would be some sort of huge cover-up going on. And I personally just don't think it's credible to think that kind of cover-up is happening in Thailand. The second point with regard to the testing that I'd just like to say is, actually, we can study the data a bit to give us some answers on whether there's an issue with the amount of testing. So one thing I looked at earlier today was with the testing that there's 150 tests for every single positive case of COVID-19. So that's quite a high ratio, much higher ratio than other countries. The other thing I look at from a data perspective is if we let's assume just for this exercise, a mortality rate of 1%. So in other words, 100 people that have COVID-19, sadly, one person would die. And that's a number that's been floated around as, somewhere close to the truth. If that were the case, based on 58 deaths in Thailand, we would expect 5,800 cases. And obviously what is being reported at the moment is over 3,000. So there's not this huge gap that actually, when we do the same analysis in other countries, that we're seeing. So really, when I look at the data, this suggests to me that, that the testing issue is not an important issue for Thailand. Now, I did say, yes, I believe in the data, I trust the data, but we have to be careful in making comparisons. I just want to give some examples of what I mean here. Firstly, I think it's dangerous to compare cases across countries because basically every country has different testing regimes. Now, I was actually back in the UK in early March. I was luckily one of the last few people to come in back at the end of March. So I'd been on a family trip. And at that point in the UK, there's only the very, very serious cases that were getting tested. So there were certain criteria that determined whether you're getting tested or not. And every country around the world has got its own criteria, and it's different in every country. Also, capacity for testing changes as well. Using, again, the UK as an example, there's very little capacity in the beginning. Now there's quite a massive capacity. So as that capacity changes, the number of cases, the more testing, the more cases we will see. So I think the case data is not that useful to compare. So the best thing I think that we can compare, sadly, is the deaths. But even that does have some issues that we need to be aware of when we're comparing deaths. The question really here we need to address is, how do you count a COVID-19 death? Now, it seems like a simple question, but actually it's not. In some countries, it's just the cases that are collected that are in hospital where there's a positive test. Some countries are recording a COVID-19 death when it's the main cause of death. Some where it's not tested, but doctors are assuming. So there's lots of different ways in which COVID-19 deaths are getting recorded, which make it difficult to precisely compare between countries. There is actually an emerging consensus around a solution for this. And that is, I think the solution will be measuring all-case mortality. And there is a consensus for this. And just to explain that for those that are not familiar, that's basically just looking at the deaths from all causes in 2020 so far and comparing that to what we would expect in a normal year. And obviously we've got lots of years of data. And then we can see the gap between the actual deaths and what's what would be expected. And we can, with quite a lot of statistical validity, we can actually make a strong assumption this is a COVID-19 related death. So I think I haven't seen Thailand's numbers for this, but that will clear it without any doubt once the numbers are available for all countries, whether there's anything fishy going on. Not necessarily fishy, but just differences in the way that deaths are being recorded. So I think that will be something to look out for. So I think in conclusion, we can trust the data, but we have to be careful because some of these issues. The data will also eventually answer why is Thailand doing so well compared to many other countries. There's lots of studies now that are coming out showing correlations, and I think eventually we'll have clear answers. But of course, today we will discuss this and put forward our own ideas, and I'm sure many of these will be found to be true eventually.
Good, thank you, Craig. Dr. Tawasin, can I welcome you to the club? You are the face of COVID-19, the battle against it in Thailand. Your life must have changed tremendously. You're a celebrity. Before we go any further, we're respecting social distancing. Are you satisfied with the arrangements that you see before you? Mm-hmm. We need your blessing. I'm very interested by the fact that your background in medicine is as a psychiatrist, and that you were selected for that position. Can you explain to us why it was that they chose a psychiatrist to be the spokesman on this very sensitive issue? Because I think it's very...
Okay, thank you so much for inviting me for this session. I have to have someone help me because of about English language. Right now I'm not familiar with like my native language. Let me introduce my Mr. Proud. He will be an interpreter. Just can help me to have accurate information for you. Okay? ครับก็ขออนุญาตถอดหน้ากากสักนิดหนึ่งนะครับกับคำถามที่ว่าเรื่องของการเป็นจิตแพทย์มันมีส่วนตรงนี้ได้ยังไงนะครับก็อาจจะได้เล่าประวัติสักนิดหนึ่งนะครับผมเป็นจิตแพทย์ในช่วงตั้งแต่ปีต้องเรียกว่าไงสัก30ใกล้ๆแล้วมั้ง20กว่าปีที่แล้วนะครับก็เป็นอาชีพที่ไม่ได้คิดว่าจะได้มาทำแต่ว่าก็ได้เรียนรู้จากเรื่องของการเป็นจิตแพทย์ที่ดีก็คือการได้มีการซักประวัติเรื่องของการซักประวัติการใช้ภาษาในการที่จะดึงเอาความสำคัญของโรคของผู้ป่วยหรือว่าเอาเรื่องของทางความเข้าอกเข้าใจของคนที่เขามาพึ่งพาเรานะครับมันก็เป็นพื้นฐานอันหนึ่งนะครับซึ่งเคยมีประสบการณ์อยู่ครั้งหนึ่งก็คือการเป็นจิตแพทย์เนี่ยมันจะต้องมีการเขาเรียกว่าทำไซโคเทอราปีหรือการทำจิตบำบัดเราจะต้องมีการอัดเทปแล้วก็ฟังเทปตัวเองแล้วก็ถอดเทปเพื่อไปคุยกับอาจารย์นั้นเราจะรู้ทั้งตัวเราเองว่ามีความคิดอย่างไรแล้วก็รู้ว่าผู้ป่วยหรือคนไข้เขามีความคิดอย่างไรเพื่อที่จะช่วยผู้ป่วยโดยผ่านการนำเสนอเคสนี้ต่ออาจารย์ก็จะทำให้เราเข้าอกเข้าใจในตัวของคนไข้ขนาดเดียวกันอาจารย์เองก็จะเป็นคนส่องมองว่าเราคิดอย่างไรเราเข้าใจอย่างไรทำไมเราถึงตั้งคำถามนี้กับคนไข้อันนี้อาจจะเป็นเบสิกอันหนึ่งมั้งที่ทำให้ต่อมาผมได้ทำหน้าที่เป็นพิธีกรในรายการทีวีต่างๆได้ด้วย
First of all, give me permission to take off my face mask. In response to your question about how a psychiatrist can contribute to solving the problem of the spread of COVID-19, allow me to give you a brief biography of my career. I've been a psychiatrist for over 20 years now. Initially, it was not a profession that I anticipated. However, it has assisted me a lot in my current job. Firstly, if you're a psychiatrist, then you have to be skilled in investigating the personal history of patients. Therefore, you'll better understand their background. Moreover, you have to be apt at using language and communication for treatment. Therefore, these are the important bases of being a psychiatrist, and these also contribute to effectively assisting the public. As a psychiatrist, we were also taught to do psychotherapy, and the method of teaching was that we would listen to our patients, we would discuss our patients' issues and record that as a tape. We would then listen to them over again by ourselves and with our teachers, and we would be able to see how we could communicate better, how we could empathize better. We would receive feedback from our own teachers, and would also get insight into our own means of communication. And all of these have contributed to me being an effective communicator and allowed me to be invited on various TV programs and talk shows in the past.
ยังจำได้นี่ขอเพิ่มตัวนี้หน่อยหนึ่งนะครับที่ว่าตรงนี้น่าจะเป็นอันหนึ่งซึ่งในช่วงหนึ่งที่ได้มาเข้ามาเป็นผู้ที่ตอบคำถามในช่วงของปีต้มยำกุ้ง 2540 ซึ่งจิตแพทย์ต้องมาทำหน้าที่ออกสื่อมากๆเพราะว่ามีคนจิตตกความเครียดฆ่าตัวตายในปีของ 40 นี่เยอะมากแล้วก็หมอทุกคนจะต้องมาเข้าอยู่เวรคอยรับโทรศัพท์ในช่วงกลางคืนนะครับก็ได้มีโอกาสได้ฝึกทักษะในการตอบคำถามนะครับจากการที่ได้เป็นคนที่ตอบคำถามคนไข้สักพักหนึ่งก็ต้องมาทำหน้าที่เป็นผู้จัดรายการวิทยุเพื่อที่จะลดความเครียดนะครับแล้วก็ได้มาทำงานทางด้านทีวีก็ได้ใช้สกิลที่เป็นลักษณะของการเป็นผู้ที่ได้อินเทอร์วิวคนไข้นี่แหละครับได้มาก็เลยทำให้ได้สกิลนั้นมาแล้วก็ต่อมาก็ถูก recognize ถูกให้ทำหน้าที่เป็นโฆษกตั้งแต่น่าจะ10 กว่าปีมาแล้วนะตั้งแต่ปี 2543 ตอนนี้เท่าไหร่20 ปีแล้ว 20 ปีมาแล้วครับก็ได้ทำหน้าที่ทางทีวีด้วยก็เลยทำให้คิดว่าไอ้ประสบการณ์ของการทำทีวีตรงนั้นแหละครับที่ได้มาสื่อสารในตรงนี้ได้ครับ
And I'd like to add a little to my biodata that I just gave you. Actually, my public presence began during the 1997 Asian economic crisis, when I had to be involved in a lot of Q&A sessions in the public arena, on TV and in radio. Back then, psychiatrists had an extremely important role in the public eye, since the Asian 1997 financial crisis had caused stress, depression, and even suicide amongst members of the public. Therefore, the government set up a hotline in order to answer the questions of the public and alleviate their stress and their concern. And I was trained in answering these questions, and I was also in charge of organizing radio programs to reduce public stress and to boost public morale. So that's where my skills in interviewing and in communication came about. And I was recognized for my abilities, so I was delegated the role of spokesperson, and that now has been going on for around 20 years.
Okay, in terms of that, when you approach Thailand as a communication challenge, what are the key ideas? What distinguishes this audience? What do you go after? Humor is one aspect of it. Most people think about Thailand as a Mai Penrai culture, not very disciplined. And yet you've shown, or Thailand has shown itself to be capable of responding quite effectively. And in fact, we saw something like this previously during the AIDS crisis in the early 1990s. People do listen. But how do you talk to the Thais? What is different?
ก็หลักการที่ได้ใช้จริงๆแล้วก็คงมาจากเรื่องของการได้เข้าใจถึงตัวโรคก่อนนะครับเพราะว่าโจทย์ที่ผมได้รับมาในการที่มาเป็นโฆษกของสบคเนี่ยก็คือโรคนี้เป็นโรคติดต่อใหม่ซึ่งเราไม่รู้จักอะไรกับมันนะครับแล้วก็ในช่วงก่อนหน้า26 มีนาที่มาทำหน้าที่นี้ผมก็ได้ทำหน้าที่เป็นผู้อยู่เบื้องหลังมาก่อนแล้วก็คือเป็นรองของคณะกรรมการ Risk Communication ของกระทรวงนะครับซึ่งได้มีการก็เรียกว่าทำหน้าที่ในการแอดมินหรือการวางแผนให้กับทางกระทรวงในการที่จะสื่อสารกับสังคมแต่ณตอนนั้นเนี่ยก็ยอมรับว่ามันมีประเด็นปัญหาอยู่มากมายซึ่งไม่สามารถสื่อสารได้โดยตรงนักแล้วก็เป็นเรื่องใหม่เป็นเรื่องที่เกิดประชาชนเกิดแพนิคเกิดความไม่เข้าใจสงสัยนะครับแต่จากประสบการณ์ตรงนั้นนะครับก็ถูกแก้ไข ในตอนที่มามีสบคตรงนี้ครับเดี๋ยวเล่าต่ออีกที
This principle that I applied initially in communicating in communicating during this crisis and in tackling the attitudes of the Thai people stems from a true understanding of the nature of the disease. Therefore, the initial main challenge was that this is a novel, a new disease with little information on it. And in fact, even before the 26th of March, when I had a constant presence in the public arena, I was doing behind-the-scenes work as deputy head of the Committee on Public Communication of the Ministry of Public Health. And there were many issues that we were confronted since we were unable to convey things in a direct and simple way due to the novelty of this disease. And there was also panic amongst the public because very little was known about this disease. And we were able to resolve all these forms of miscommunication through the integration of our communication under the Center for COVID Situation Administration.
ผมสรุปเร็วๆเลยก็เลยนะว่าใช้หลักการอยู่ประมาณสัก3ข้อนะครับอันแรกก็คือถ้าเป็นเรื่องที่เกี่ยวข้องกับประชาชนนะครับสิ่งที่ต้องมีอันดับแรกก็คือเรื่องของความไว้วางใจจากพี่น้องประชาชนที่จะต้องรับข้อมูลข่าวสารนี้ซึ่งสิ่งที่มันเกิดขึ้นก็คือเขามีความกลัวเขามีความตกใจเขามีความไม่สบายใจมีความไม่รู้ในหลายๆเรื่องก็เลยทำให้เกิดปัญหาขึ้นมาเพราะฉะนั้นหน้าที่ของเราคือต้องเปลี่ยนแปลงไอ้ความกลัวนั้นออกมาเป็นเรื่องของการมีความกล้าที่จะไปต่อสู้กับเรื่องโรคนี้อันนี้ก็เป็นหลักการอันหนึ่งก็คือโดยการให้ใช้ความรู้ต่างๆที่เกิดขึ้นมานะครับก็เลยเกิดขึ้นเป็นลักษณะของการแถลงข่าวรายวันเพิ่งจะต้องแก้ไขความรู้ตรงนี้ให้ได้ก่อนนะครับเรื่องของความกลัวเนี่ยนะครับอันที่สองก็คือเป็นเรื่องของการมีตระหนักรู้หรือว่าความระลึกรู้ว่าไอ้โรคนี้เป็นยังไงเพื่อที่จะปรับตัวเองปรับอะไรทั้งหลายซึ่งระหว่างความกลัวมาสู่ความตระหนักรู้แล้วนำไปสู่ attitude การปรับเปลี่ยนเนี่ยมันอยู่ในวิชาทางด้านสุขภาพจิตอยู่บ้างแล้วนะครับนั้นการจากความรู้สิ่งที่จะต้องผสมผสานปนเปไปก็คือต้องให้เขาผ่อนคลายเขาถึงจะได้เรียนรู้สิ่งต่างๆนี้กับเราได้นะครับแล้วนำไปสู่การยอมรับแล้วก็เกิดการปรับเปลี่ยนไปสู่การปรับเปลี่ยนตัวเองแล้วก็ปรับเข้าสู่โหมดที่เราจะต้องการให้ได้อันนี้คือภาคของประชาชนนะครับโจทย์ที่ถัดไปตรงนี้เองก็คือว่าจากความรู้เรื่องโรคเนี่ย 90% ของคนไทยต้องยอมรับในวิธีที่เรากำลังจะใส่ให้เขาไม่ว่าจะเป็นเรื่องของการใส่แมสถ้า 70% ของคนร่วมมือเนี่ยเรื่องของ growth rate มันยังเรื่องของการติดต่อมันยังสูงขึ้นมาถ้า 80% ก็ยังชันอยู่นะครับในเรื่องของการอัตราการติดเชื้อเพราะฉะนั้นถ้าตามทฤษฎีแล้วมันต้อง 90% มันถึงจะสามารถที่จะกดสโลปนี้ได้เพราะฉะนั้นสิ่งที่เกิดขึ้นก็คือว่าประชาชนเป็นส่วนใหญ่ที่เราจะต้องทำหน้าที่นี้นี่ก็คือเป็นหลักการที่ผมได้พยายามที่จะใช้ตลอดมาครับ
So let me give you a brief summary of the three key factors that I've applied in tackling this illness and in communicating about the spread of the disease. Firstly, the public has to be wholly involved. There has to be trust from the public in receiving the information that we convey to them. At first, before we started conveying clear information, there was fear, there was panic, there was misunderstanding, leading to problems relating to that behavior in containing the disease. However, we were able to get a public message across to transform this fear into courage and transform it into action. Therefore, what did we do? We used the information and the scientific evidence that we had in order to educate the public, and we held daily press briefings so that they'd be better educated and that they'd see the rationale behind our methods. Secondly, there has to be awareness. So we have to know what is at the core of the spread of this disease, what is at the core of this illness. After that, we can adapt the mindset of the public accordingly so that they can act in a way that is best suited to stopping the spread of this disease. And in the task of adapting the mindset of the public, I had my training as a psychiatrist to thank. Once the public, as psychiatrists realize, once the public are in the right phase of mind, then they're more willing to accept the message. Therefore, the issue of ensuring the right mindset of the public was key. Once the mindset could be gained, then therefore the public could adapt in terms of their behavior and adapt to the measures that the government wished to issue. Next involves the wholehearted cooperation of the public. It is commonly accepted that in the spread of such a disease, 90% cooperation and partnership from the public is required. 70% is not sufficient, as it still enables the disease to spread considerably, and with 80%, we're still talking about a risky environment. Therefore, only 90% or over of cooperation can truly flatten the curve. Therefore, I ascribe our success mainly to the spirit of cooperation shown by the public.
If I could just ask you, Dr. Davidson, you are the spokesman for the Center of COVID-19 Situation Administration, and there have been a few occasions where it seems that you're not quite aware of what's happening. For example, the opening of schools. We heard on the Friday before many schools were expected to open, it was announced that they would stay closed. And on the issue of alcohol, where the impression that was being given was that the alcohol ban would not be lifted, but in fact, when the royal decree came out, the proclamation, it was lifted. The issue here is who is making the decisions. You are the spokesman, you have to relate and present things, but who actually makes the decisions? I know it's not you, but is it the CCSA or is it Ministry of Public Health? Where are the decisions made?
ถ้าพูดถึงเรื่องของเดี๋ยวนะผมกำลังจะทวนชุดข้อมูลก็คือเพราะว่าเรื่องของแอลกอฮอล์ที่ห้ามขายแอลกอฮอล์แล้วก็กลายเป็นว่าขายได้อ๋อเหรอฟังตรงนี้เสียงไม่ค่อยเข้าคืออะไรนะ
มันจะมีอยู่ที่เวลาบางครั้งข้อมูลออกมาแล้วเหมือนกับว่ามีการตัดสินใจแล้วประกาศออกมาแล้วก็ไม่เหมือนกับที่ประกาศเช่นในเรื่องของวันเปิดเทอมของโรงเรียนหรือว่าในเรื่องของว่าห้ามจำหน่ายแอลกอฮอล์แล้วก็เพราะฉะนั้นก็คือใครเป็นคนตัดสินใจตรงนั้นแล้วทำไมคุณหมอถึงไม่ทราบว่ามันมีการตัดสินใจหรือว่ามีการเปลี่ยนการตัดสินใจภายหลังค่ะ
อ๋อถ้าเป็นเรื่องของนึกว่าเรื่องของการขายแอลกอฮอล์อย่างฟังแล้วงงคือหน้าที่ของผมในฐานะที่เป็นโฆษกสบคก็คือมีการรวบรวมข้อสรุปจากการประชุมนะครับซึ่งต้องบอกก่อนว่าสบคเนี่ยมีชุดจากเดิมตอนเริ่มต้นเนี่ยมีไม่กี่คณะนะครับเพราะตอนหลังมาเนี่ยเพิ่มขึ้นมาตอนแรกมีแค่8หรือ9ตอนหลังมาเป็น10กว่าคณะนะครับเพราะฉะนั้นก่อนหน้าที่จะมีการประชุมชุดสบคใหญ่เนี่ยจะมีการประชุมชุดย่อยๆตามมาก่อนข้อสรุปในบางเรื่องอาจจะมีการสรุปมาก่อนการประชุมนะครับซึ่งก็อย่างการประชุมครั้งล่าสุดเนี่ยก็มีการสรุปออกมาก่อนการประชุมนะครับแล้วก็แต่ยังไงก็ตามแต่ในดีเทลหรือในรายละเอียดบางเรื่องเนี่ยอาจจะไม่ได้ตรงนะครับหรืออาจจะไม่ได้ตรงกับการสรุปเช่นเรื่องของการเปิดเรียนตอนแรกก็ว่าจะมีและเสร็จแล้วก็ไม่มีนะครับซึ่งอันนี้มันเป็นการตัดสินใจรอบสุดท้ายของการตัดสินในวันนั้นแต่บางทีก็จะมีข่าวออกมาก่อนว่าจะตัดสินใจอย่างไรนะครับซึ่งเรื่องนี้ก็เป็นเรื่องที่ทางผอ.สบคก็ให้ความสำคัญนะครับก็เลยว่าต้องมีการรวมศูนย์ในการที่จะต้องแถลงข่าวออกไป ถามว่าตัวเองเคยมีผิดพลาดบ้างไหมก็พอมีบ้างแต่ว่าก็ในบางเรื่องก็เป็นเรื่องเล็กๆน้อยๆซึ่งเป็นรายละเอียดเช่นวันที่หรืออะไรต่างๆนะครับหรือดีเทลสิ่งในรายละเอียดเท่านั้นแต่ในเรื่องใหญ่ๆเท่าที่ได้รับทราบก็ยังไม่ได้มีข้อขัดแย้งอะไรนะครับซึ่งเราก็สามารถที่จะผ่านประเด็นต่างๆของเรานั้นไปได้
My duty as a spokesperson to the CCSA is in order to compile the summaries of each daily meeting under the CCSA. So the CCSA has many subcommittees. Initially there were only a few subcommittees and it grew to 8 to 9, then 10 subcommittees. And there'll be a meeting of the overarching committee after the meeting of each subcommittee related to each area in tackling the spread of the disease. So there might be resolutions under subcommittees first, and these resolutions will be released for each subcommittee. But the details of these resolutions can be amended later in the day by the overarching committee. Therefore, the final decision rests with the larger committee. And sometimes news has to be released first concerning the resolutions of the subcommittees. The director of the CCSA has addressed this problem, and he says that there is a real need for integration in the communication of resolutions. And of course, if you were to ask whether I've made any mistakes in my communication, I have made some, but I feel that these shortcomings concern only minor details, such as a change in dates, which is later decided upon or finalized by the overarching committee. However, these shortcomings do not constitute a whole contradiction between what I say and the decisions of the overarching committee.
And just briefly at this stage, what is the future of the CCSA? What do you see rolling out over the course of this month?
ครับก็ในตอนนี้นะครับอันนี้เป็นความเห็นส่วนตัวอย่างเดียวนะครับยังไม่ได้เป็นเรื่องของทางการประชุมของสบคนะครับจากความเห็นส่วนตัวก็คิดว่าเรื่องของการเกิดขึ้นของสบคเนี่ยเป็นเรื่องของการเกิดขึ้นมาเฉพาะกิจเพื่อจัดการกับปัญหาเรื่องโรคไวรัสโควิด -19 นะครับซึ่งตอนนี้เราก็ได้รับคำชื่นชมว่าเราก็ได้ทำได้ดีแล้วก็จัดการกับปัญหาได้จนกระทั่งตัวเลขของการติดเชื้อเป็น0ณตอนนี้หลายวันติดต่อกันก็มีแนวคิดอยู่หลายแนวคิดนะครับก็เกิดขึ้นอันแรกก็คือว่าถ้าเสร็จสิ้นภารกิจนี้ไปสบคก็ควรจะต้องจบไปด้วยนะครับก็น่าจะต้องหมดภายในช่วงเวลาของสิ้นเดือนนี้อันนี้ก็เป็นแนวคิดที่1แล้วก็กลับไปสู่สภาพปกติคือกรมกองต่างๆที่ทำงานก็ต้องรับผิดชอบนี้ไปแทนแต่แนวคิดที่2บอกว่าถึงแม้ว่าตัวเลขจะดีนะครับแต่ว่าการติดเชื้อของต่างประเทศนะครับยังมีแนวโน้มที่สูงก็ยังเป็นประเด็นเป็นปัญหาอยู่รวมกับเรื่องของแนวทางในการรักษาก็คือยังไม่มียารักษายังไม่มีวัคซีนในการที่จะทำให้โรคนี้มันหมดไปถึงแม้ตอนนี้จะเป็นตัวเลข0แต่หน้าที่ทางด้านการควบคุมโรคยังต้องคงอยู่นั้นแนวคิดที่2เนี่ยก็อาจจะต้องมีการยืดเวลาต่อไปของสบคนี้ซึ่งอาจจะเป็นได้ทั้ง1ทั้ง2นะครับงั้นการยืดเวลาออกไปนี่ก็คือก็ต้องต่อเวลานะครับแต่ในความคิดที่3ก็บอกว่าก็ยังใช้1กับ2นะครับแต่ว่าไม่ต้องอยู่ในรูปแบบของการเป็นสบคก็อาจจะอยู่ในรูปแบบอื่นๆเช่นเป็นคณะกรรมการข้อดีของการมีสบคคือการได้มีการบูรณาการงานของหลายๆกระทรวงที่เราไม่เคยทำอะไรมาก่อนอย่างนี้ยกตัวอย่างเช่นการมี State Quarantine ซึ่งต้องเป็นการประกอบร่างกันของทั้งกระทรวงสาธารณสุขทำงานร่วมกันกับมหาดไทยทำงานร่วมกันกับกลาโหมแบบใกล้ชิดกันแล้วต้องเฝ้าดูแลบุคคล 3-4 หมื่นคนในตอนนี้ที่เราทำกันมาซึ่งแน่นอนว่าถ้าเปิดเมืองเข้ามาอีกจะต้องมีคนที่จะต้องเดินทางเข้ามาอีกต้องใช้บริการอย่างนี้อีกนี่แค่งานเดียวยังมีงานอื่นในเรื่องของที่เกี่ยวข้องกับเรื่องของการเดินทางนะครับที่จะระหว่างประเทศเรื่องของการเปิดระหว่างสนามบินอะไรต่างๆอีกมากมายนะครับซึ่งสิ่งต่างๆเหล่านี้ต้องการการทำงานแบบ บูรณาการแต่อาจจะไม่ได้ในรูปแบบของสบคก็ได้ก็เป็นรูปแบบของคณะกรรมการเฉพาะกิจหรือจุดๆอะไรก็แล้วแต่ซึ่งจะเป็นได้ทั้ง3รูปแบบที่จะเกิดขึ้นในข้างหน้านี้
What I'm about to present to you is my personal opinion, and it has not become the official resolution of the CCSA yet. However, I feel that there might be 3 alternative directions for the CCSA. The CCSA was established as an ad hoc group, especially to tackle COVID-19, and since there have been no recorded domestic infections for over 2 weeks, many have put forward the idea that the CCSA should be terminated within 6 months' time, and the various tasks now under the CCSA can be delegated to the relevant agencies responsible for those tasks. The second option is that comes from the argument that although the figures are now good in Thailand, international numbers are still growing, and there is also the question of a cure, that no vaccine has been found yet. Therefore, our task has to be continued, and the task of containing the disease should be extended. Therefore, the second option proposes the extension of the period under which the CCSA can be operational. And then the third alternative is that the CCSA can be continued, but no longer in the form of a center, but perhaps as a committee with a different type of role and a different type of status. The strong point of the CSA was that it was able to integrate the work of all agencies. We're talking about security agencies, agencies related to foreign affairs, the Ministry of Interior, and the Ministry of Public Health. This is seen in the way 30 to 40,000 people had to undergo state quarantine, and this required cooperation between all departments. And these services will continue to be required. Therefore, and there remains other work indirectly related to the center, such as putting controls on international travel, questions concerning reopening airports, and these still require the integration of all departments. Therefore, the CCSA might still be operational, but under a different name or under a different form.
Thank you. Right, at that point, I'd like to move forward to Dr. Tanarak, who has a brief PowerPoint outlining 7 key factors in the Thai response. His materials also, there are also some other materials that were circulating, and they include excerpts of Prime Minister Prayut Chan-o-cha's address to the nation on the 25th of March, which was an important moment, and what was said then was much stronger than has appeared in English. And also, Dr. Tanarak tonight will highlight 5 key dates in the battle against COVID. Dr. Tanarak.
Thank you very much for having me here again for the 3rd time.
You can take out a membership if you like. You know.
Okay, thank you. First of all, I think I would like to start with the situations and tell you I think what is the very important key date and how it happened, and tell a little bit of a story of how things rolled out. Everybody knows that the COVID-19 started around January of last year. December 31st, Chinese government report the new cluster of pneumonias to WHO. That is the first information we get. And on the January 3rd, that is our first response began. That is when we activate our emergency operation system at Department of Disease Control. And we all know that on January 8th, we have the first cases. And we start to have cases in January. Most of the cases are all imported cases, but we first have our first local transmission on January 31st. During February and early March, we have local silenced local transmission, but most of the cases are from abroad. And on March 13 is very important date for us. It was the first time that we have a report of a large clusters, actually two of them. One is from boxing arenas and the second one is from a nightclub in Sukhumvit areas. And on March 17, that is the date that our cabinet agree and have a resolution to close down some high-risk places and some high-risk business. And on March 24th is the date that we declare a state of emergency effected on March 26th. And after that, there are a lot of social intervention or social measures that has been used along with other public health measures. And May 3rd, just about a month and a half after we declare state of emergencies, we start to reopen again. I would like to address our 7 things that I think we do right along the same as chronological times. So before the outbreak begins, we know that we have a very strong public health system, or what we call strong health security system already. I think it's already in the news that we are 6th in the world and 1st in Asia in these categories, and we have scored very high in several other indicators. We know that we are quite good, and last time I already said this. We know that we are good, but we don't exactly know how good we are when we have to fight COVID. And now I think time has already told us that how good we are. Second thing is that we react very quickly by activating the system on January 3rd. Helped us quite a lot. We have been able to bring in a lot of staff, a lot of people, and learn along the ways of doing things. These things help us react quickly and help us stay ahead of the epidemics. The third things from the beginning is that not after CCSA, even from the beginnings, you can observe that most of the response lead by health expert, not just some other people who don't know things about it. Most of our recommendation has been implemented by health authorities and later on by the government. So all of the things that we recommend or we think that is good for our societies has been actually implemented later by the authorities. Then after we have situations in middle of March, and we have to collaborate between different departments, different ministries. The ministry step up and take the lead by himself. That kind of calm down every argument or have situation that we have between ministries and help us going through the very difficult situation during that time. There are a lot of collaboration, a lot of meeting that we have to do and discuss with different ministries so that everybody know their roles and help us in responding to these situations. So that is very helpful. And then with that, what we have next is a very comprehensive multi-sectoral approach, not just by the government, but also by the private sectors. A lot of private sectors step in and help us doing a lot of things, not just what we do as a government. You can see that the Sky Train and every sectors during the month of April, when we ask for help in having their staff work from home, it's not an order, but everybody kind of helpful. We can see the statistic that's the number of people using SkyTrain dropped by close to 80%. Those are the things that everybody's come in and help. Then at the same time we have, I would like to call it Unifying Communication. Dr. Tavisin have done quite a great job and everybody should know that. But if you look at how we communicate, not just from one single person, but everybody talk in the same ways, not just from CCSA, But even the technical parties like universities, everybody talking in the same ways, helping each other. And in the end, the last point that I would like to make, when crises come, you can see it all the time. Thai people come together and help each other. I call it Bangrajan spirit. And I think if you are in Thai long enough, you understand what it is. When the crisis come, every time, last 2 years we have a crisis up in the north. If you remember, there were 13 white-born teenagers with soccer teams stuck in the cave. Everybody kind of chipped in and helped each other quite very good and help us getting out of the crisis very well. I think those are things that I think very important that help us from middle of March and to this point. I think those are the factors or the things that we have done well.
It's interesting. You bring up the cave, which was an international effort, and everybody cooperated, and it was a very good news story. Thailand, we have the Bangrajan spirit that you're talking about. Actually, Thailand has gone its own way, particularly on this issue of testing. Who said test, test, test? Thailand has not done that. Thailand has taken a strategy that is much more economic and has actually not been shown to be incorrect. Now, can you explain more about that? And also, how many tests have actually been done in Thailand? I know that you have laboratories in all the provinces and everything is up to speed now. You can do tests. But the fact is that testing was not core to the Thai strategy. Can you explain?
I would like to say that testing is very important, and we are doing it at the moment. But in the beginnings, we are not doing that much testing, and I think it has been the question of the ways that we do it. Now, I would like to explain this by giving you an example. In the past, during the HIV crisis, during the HIV epidemics, there are two ways of doing operation of the patients. First, you are testing them before doing operations. And the second way to do it is that you assume that every patient you are going to perform operations is HIV positive. And we call that universal precaution. You assume that everybody you are going to treat, you are going to operate upon is infected. Those are the approach that we are using during the crisis. If you look back, we are using the strategy that we ask every Thai, no matter you are well or you are having cold symptoms, to wear face mask. Is exactly the same of what we do in our approach with HIV. Testing is very important, but it is not the only ways to get out of this problem. Just look at this. Let's say that if there are 1,000 infected person in Bangkok now, for example, just give you a numbers. And do we have to know that who is those 1,000 in order to just get rid of it? The answer is not exactly. If you want to know it, you may have to test 8 million people to find those 1,000. But let's say that if everybody's 8 million people apply what we call universal precaution, everybody's look after themselves and also trying to prevent, just as if they are infected with COVID, and also trying to prevent themselves from getting COVID from anybody. That ways can also reduce the number of affected person in the future as well. So those are the approach that we have. Plus one things, that is we are using what we have and what the other don't have, is that we use our strong epidemiological teams. We have more than 1,000 teams in Thailand, and the number is growing very fast because we are keeping training those investigation teams. Those are the ones who go after infected person. If we identify any cases, in the past we were able to investigate every single case we investigate to identify who is the contact, and then we trace those contacts, doing the contact tracing, and follow them for 14 days. Those are the two strategies that we are using. Although we are not testing as much as the others, but what we say, we use strategic testing methods, where we identify the high risk close contact, and we test all of them. We don't test a lot. We don't test the low risk close contact. Let's say, for example, if there is anybody in this room is infected, and if you just walk past them, you are not going to be tested if you don't have any symptoms. Low risk close contact we did not test quite a lot, but other countries may test quite a lot. One of the reasons, I think I explained it here also, that if you look at high risk close contact, the percentage of positive is also very low, between 2 to 4%. If you test low risk close contact, you probably see less percentage of positive. And we also know that in our heart that we have other things or other methods to be able to stop them from spreading the disease. So using the strong measure of public health measures, and also with universal precaution that was very successful during the month of April, that is, I think, brought things together. That is the strategy that we use during the time that we don't have enough testing.
Right, and Vietnam has used a very similar system of chasing every suspicious lead, and they've come out with 0 deaths. Since you brought up the teams, could you also tell us a little bit about the health worker network? The health worker network that you have all through Thailand. I believe there's 1 million people involved in this, and that's very, very different to most other countries.
Right. As I mentioned earlier, our health infrastructure, especially for health security system, is very strong, and it has been implemented for more than 40 years. Not just only the epidemiologists, but also village health volunteers. Yeah. At the moment, we have more than 1 million of them, about 1.04 millions of village health volunteers. Our system is that we have provincial health office led by provincial health chief officers. Under that, we have what we call hospital and also district health office. Under that, we have what we call health promotion hospital or health centers. Health center is the one who taking care of all of the health volunteers. Health volunteers have to work with health promotion hospitals in order to help them do what is necessary to do in their areas. What is the priorities of their village, or what is the priority of their sub-district. So health volunteers work closely with health promotion hospitals. The other set of team that we have so many is, we know that we have not enough epidemiologists, few epidemiologists, so we create a lot of what we call communicable disease control unit, CDCU, communicable disease control unit. We have at least one CDCU for one district, and they are work under provincial health office. So they come together. For example, if this province has about 20 districts, then they should have at least 20 communicable disease control unit, so that they can go out and investigate the case, doing contact tracing with village health volunteers. So that is how we can organize how can we manage to investigate every single case that we have. There is about 3,000 of them at the moment.
And usually they'd be tracing dengue and malaria and...
Yes, they are working not just COVID, and they are working
diseases,
with other things.
Okay, thank you very much. Matthew, you're the editor of Southeast Asia for Reuters, one of the largest news gathering organizations in the world, still surviving. What have you been seeing, starting off with Thailand? I know you have a regional perspective.
Well, it's very interesting to look at the way that different countries in the region have responded, and it's very interesting to look at the results that we've seen in those different countries, how the disease, how the epidemic has played out, or in some countries is very much still playing out in those places. So if you look at Thailand within the context of Southeast Asia, it certainly seems to have done well in that we're at this point now when we've had sort of no local transmissions for a couple of weeks. The number of deaths has been relatively low compared to Indonesia or the Philippines. The number of cases that have been found have been relatively low, even compared to Malaysia or Singapore. But it's worth looking at how those countries also have sort of gone about responding, the different levels of testing, which is a factor then in being able to sort of identify what's really behind the spread of the epidemic in different places, but also to try and think about what factors have been effective in being able to control things. And it's very hard to tell that. I mean, our first job is to try to find out very much the facts about what the extent of the epidemic is, what are the facts about what's the true number of deaths, what's the true number of infections and the degree of testing that's been going on and so forth. But then there's any number of factors that people sort of put forward as to why it might be that a country's done better or worse. Is it to do with sort of warmer weather? Is it to do with the effectiveness of a government response, people wearing masks, people having a culture of not hugging each other? Is it to do with race? Is it to do with demographics? There are all these factors which people talk about, which are very much harder for us to prove. But getting back to the first point and to what Craig was saying about numbers and things as well, it's our job to try and explore these things in different countries. It's our job to sort of challenge and try and find out what the real figures are. So, for example, in Jakarta in Indonesia, one of the things that we were able to do was by the end of March to find that there had been 1,000 more burials in Jakarta in March than had happened in any month for, in fact, as it turned out, since their records began, which was clearly an indication that something massive was going on and that coronavirus was the only sort of clear explanation for it. Of course, we tried to do the same thing in Thailand as well, and didn't find that there was this huge number of sort of excess deaths. There wasn't a large number of people who had who died for unexplained reasons. Or I remember early on there were sort of suggestions floating around that the number of pneumonia cases was much higher than normal, but they weren't being classified as COVID-19. We looked at that. We found out that it wasn't really the case. So in terms of being able to sort of trust the numbers for deaths and things, I mean, we've done everything that we can to try and test it, and haven't really found it wanting in that sense. Now, when it comes to the number of cases, that's harder to judge because, of course, it really depends on the amount of testing that you're doing to be able to find out. If you're not doing the testing, you're not going to find the cases. In Indonesia, again, then very, very early in there, it took them longer than other countries, almost any country in Southeast Asia, to find a case because they were testing very little. And then when they did start testing, they started finding quite a lot. And even if you compare, if you compare the sort of relative number of deaths to the number of cases in different countries around the region and things too, you find that may be an indication of the level of testing as well as anything else. So, for instance, in actual fact, the number of deaths per person tested, per number of people tested, is actually lower in Malaysia than it is in Thailand. And you don't normally think, well, they've done a fantastic job of dealing with things. I mean, particularly after the sort of disastrous event that happened in a mosque in Kuala Lumpur, which spread hundreds of cases around the region. But that's probably or may well be a factor of the fact that they've actually done more testing than Thailand has. They found more cases. They've had more deaths. But if they've done more testing, then it appears as though the rate is somewhat lower. The other country that I'd really sort of refer to in the region as well is Vietnam. We mentioned earlier about the sort of testing rates and things there, how they'd done something similar to Thailand. And they did, but they went at it with sort of even greater vigor. I think we mentioned a figure of 150 tests per positive case in Thailand. By the time Vietnam said that it had tracked down every sort of local case that it could, it had done nearly 800 tests per positive case that it had found, and it was the highest in the world. There was one village in Vietnam of 15,000 people where they tested everybody because they thought there might be a case, and they found nobody. But they still tested the entire village. So that's certainly one of the factors which, from Vietnam's perspective, which is probably sort of seen as the very most successful country in the region in terms of dealing with coronavirus, has been sort of a big part in their success, as well as things that we've heard in Thailand, for instance, the sort of community spirit, everybody rallying together, authorities with a sort of close eye on what people are doing. But one of the things that's also still a bit unexplained, really, I mean, and if we look particularly at mainland Southeast Asia, and this again, we've tried to find the figures to show that things perhaps aren't what they appear. But if you look at the countries in mainland Southeast Asia with much weaker health systems, Cambodia, Laos, and Myanmar, even there, we're not really seeing, we haven't sort of seen huge piles of bodies piling up or anything. There hasn't, it may well be the case that there are many more cases than are being reported. In fact, it's interesting that Cambodia says that it's not had cases for many weeks, but recently somebody arriving in Vietnam from Cambodia tested positive, which suggests that it may not be completely true. But even there, the fact is, in a lot of this part of the region, the number of cases, even in places which have taken apparently less intervention, seem to be much lower, certainly than if you look at Europe or the US. I mean, in the county where my parents are from, it's got a tenth the population of Bangkok, and it's got more than 400 dead. It's very stark that this part of the world, for whatever reason, has got off far more lightly than other parts of the world. But there's also, I mean, in terms of the lessons from Southeast Asia, I think it's also very interesting to look at the example of Singapore too. Because if you look at Singapore, they thought they were dealing with it incredibly well. Probably at a certain point, they were sort of held up as the example of the country that was doing best in the world. They'd been testing all their cases, they'd been following them all up, they'd probably done more testing than anyone else. They still have them more than anyone in the region. But what they hadn't done was test the migrant workers who were living in dormitories. And when they started doing that, they started finding not just thousands of cases, but tens of thousands of cases. Tens of thousands of people who had the virus. They tested positive for the virus. Many of them weren't sick at all. Many of them didn't have symptoms at all. They were all relatively young, fit people who weren't sort of showing any of those signs. But it's also an indication to some extent of how even when things appear to be sort of going well, there are potential sort of blind spots and things which can appear. And that sort of really showed up there. If we look across the region, of course, the biggest challenge remains very much in Indonesia, which has suffered far more heavily than any of the other countries in the region, even according to official figures. But when we're looking at data and things, Indonesia actually even has a sort of separate category for people who died with symptoms that can only have been COVID by anybody's estimation. And those figures are sort of still several thousand people higher than the official death toll and things too. So that's still the part of the region where things are sort of where it's most difficult to bring things under control.
Matthew, if I could just interrupt you. In Reuters reporting, have you encountered any obstructions? Have you come across blockages? You were telling me an interesting story about Vietnam.
Yeah, I mean, look, everywhere. I mean, I think there's the challenge, and particularly initially, of being able to get hold of information about what's going on. Partly that it wasn't necessarily released very early, partly that governments didn't necessarily have that information, particularly if they hadn't been doing the testing. And if you don't test, you don't find. So the case of Vietnam was an interesting one because we went absolutely all out when we were writing a story after they'd said that they'd managed to sort of reduce the cases down to there were no more transmissions, and they'd got 0 deaths and things. So one of the things that we tried to do there was exactly as we'd done in Indonesia, in terms of checking with funeral parlors, checking with local authorities about whether there'd been burials and so forth, and we couldn't find any. There were none at all. I mean, it did seem very much, as all the experts said as well, that there actually had been, or that it's very hard to say that there'd been no deaths, but certainly a very, very low number and nobody had been able to identify one. But it was interesting that we were actually, there were some sort of nationalists who took this as a sort of an affront, that we had been sort of questioning the official figures, rather than that our work had actually sort of proven that the official figures were largely correct. I think in terms of the other direction, the biggest challenge has probably been in Indonesia in terms of trying to get accurate figures, which isn't necessarily that they're withheld, but that they're sort of classified in different ways, which makes it very hard to get a really clear picture of the sort of extent of transmission and so forth.
Great. James, you've been very, very patient in Australia. It's 10:15. You're not nodding off yet.
11:15.
11:15, sorry. You're a great observer of Thailand and its structures and institutions. People quite often focus on the governments and forget about the civil service and other institutions which are very well developed and keep going all the time, irrespective of politics. What's your take on this whole COVID-19 pandemic?
Well, I think it's another demonstration of what you were saying, that Thailand is well administered but poorly governed, if you like. It's on governance, whether you're looking at sort of the bigger picture where you have continual political instability, coups and crises of various types, or as you saw in the early stages of this COVID crisis, lack of coordination, again, was a sign of absence of political leadership. But Thailand is well administered. When you look at the executive government of Thailand, I think it's useful to think of it having sort of two arms, as a political executive and an administrative executive. And the administrative executive has actually served Thailand extremely well. I was struck by this because between my two postings to Thailand, I was posted to Malaysia, which in so many ways, its economy and other features of Malaysia, it's been in some ways more successful. But in fact, you soon observe that the public administration of Malaysia is much weaker than Thailand, with the exception of a couple of ministries which are on par with Thailand. But across the board in Thailand, it struck me that the administration was quite strong. And I made it almost a pursuit of mine to question people as often as I could who were exposed to Thai civil servants and civil servants from other parts of the region. And I found that without exception, people concluded that the civil service of Thailand in Southeast Asia was second to Singapore. And if you include North Asia as well, only Hong Kong and Singapore had civil servants who, in average terms, were considered stronger than Thailand's. And you see that notwithstanding the political instability that Thailand has had over many, many decades. Over those same decades, poverty has decreased from 65%, I think it was in 1988, to about less than 10% now. And when it comes to public health, if you have a look at measures like life expectancy, infant mortality, maternal health, family size, those sorts of things, again, Thailand has done very well. Again, another sign of the strength of administration. And until this crisis came along, I hadn't been aware of these village health volunteers. And that was just an incredible story. They're quite unique to Thailand, and the comment was made about Singapore, sort of finding amongst their migrant population large numbers of people with the virus. These village health volunteers are also deployed in Thailand into the migrant communities. So they are covered. Again, just another example of the strength of administration, which is in contrast to sort of the political executive, if you like, which struggles to get as many gold stars.
Yeah, you say that, but on the other hand, the political executive has actually stood back and deferred to expert opinion in a way that's quite striking. Would you agree?
Yes, I think that's true, and more so than I think they did during the flood of 2011, where the political executive tried to sort of stay more involved. But I think what's happened in Thailand there has been true of many countries, including Australia, where the politicians got off to a shaky start, but have realised that this is a serious health crisis and you really need people with expertise to take the lead.
Okay, there's been concern that various measures have been taken to monitor people, to increase the observation of citizenry in a public health capacity, but obviously this has implications going forward. Do you think that Thailand can wind back that authoritarian trait that might concern some more liberal people?
Yeah, I think people are right to be concerned, but history shows that Thais have a capacity to be able to wind back these sorts of things, that you have waves of greater democratisation and greater authoritarianism. We've been waiting, I guess, for a little while for more signs for the democratisation wave to sort of grow a bit. There were signs of it before this crisis came along. The crisis has sort of quelled it to a certain extent. But people, I think, are right to be wary about these measures, but also I think there's enough awareness within the community, and ultimately there'll be enough resolve to stop them sort of becoming totally dominant.
Right, but there's also an element of compliance. If people don't want to cooperate, they won't. And it was quite interesting, in Pattaya they attempted a complete lockdown one afternoon and they gave up after 3 hours. It did not work. So at the moment there is compliance. People are going along with it. They can see the benefit. It's been well communicated.
Yeah, on the question of compliance though, I've had messages from a couple of Thai friends who, have to, as they go into a shop, if they want to get into the shop, they have to put down their name and their phone number. Well, they put down whatever sort of name they want and whatever phone number they want. It's not related to reality at all.
Old habits die hard.
Yeah.
All right, look, I'm going to open the floor to the people we have here. Also, for people watching on Facebook, you can communicate with us through Jonathan, who's handling those questions. And whilst people are sort of moving around, I'd just like to ask Dr. Thanarak one specific question that basically was alluded to by Matthew, and that is the idea that there is some innate regional resistance, that people in this part of the world may, and I'm not detracting from anything that's being done, but may actually be more resistant to this disease than elsewhere. Is there anything that you've come across to suggest that there may be some truth in that? I know there's a fairly serious Oxford study going on at the moment.
I don't think that's happened. I mean, if you look at the situation that we have during March,
right,
everybody gets very scared. I mean, there was an estimate of we may have an catastrophic event, just like what the U.S. and Europe have. I think after you look at what happened in the middle of March, you can see that we have done right things.
Right.
With collaboration of other sectors, of every sector that's come in and help. And you also mentioned about Thai people really comply to our recommendation, and they do their part to help the government, to help public health system to control this disease.
Right. Gwen, are you waiting to ask a question?
Hi, Gwen Robinson. I'm president of the FCCT, and tonight I am asking a question for a member who can't be here, Karen Emmons, and she wants to ask Dr. Tanarak. She says, of the thousands of tourists from Wuhan who came to Thailand in January and February, do you have a sense of how many may have come with the virus, and why that didn't trigger an explosion of cases in Bangkok or wherever they went? I have another question, but I'll wait till you answer that.
Actually, if you look back at the numbers, you see a few things. The epidemic may start in China, in Hubei, even probably before the times that they estimate that they have the first cases. Because if you can see, by the times that they closed down their cities, after that there are so many cases still reportings. And the Chinese government also mentioned about they do the testing only for the one who have severe symptoms. They don't care to identify the asymptomatics. So if you look at the numbers in China, you see that they have very little or very small proportion of cases that are asymptomatics. So they are not chasing around the very mild cases, and the mild cases is not that a lot during the first few months. So they have epidemics that just start growing by the times that they shut down the cities of Wuhan and also Hubei province. That is around the end of January. So only the first month of January that the epidemics is not really taking off to the level of large outbreak yet, that we have to face the tourists that coming in. And if you look at the numbers that we have, most of our very first cases are all from China, Thai, and also the Chinese. I cannot exactly remember the numbers, but what we trying to do during that time is that we have the screening at the port of entries, and we also set up the system so that everybody can get involved. Not just us trying to catch the cases, but also we ask the tourist industry, the hotel, the places that they use, that they like to go, to help us identify cases. And we were able to identify cases through that channel also. The tour guide help identify cases and take them to the appropriate hospitals to be tested for COVID-19 during that times. So our system is not consist of only port of entries, but also at the community level and also at the hospitals. Those help us to be able to identify case very quickly. And one other thing that is important to know is that most of the cases that imported from China were detected very quickly. Our median times of having first symptoms, and by the time of detection was around 3 days, which is a lot shorter than other countries as well. So those kind of things that I think help us identify the cases very early and help us to be able to control the disease later on.
Gwen, you have another one?
Yes, sorry, this is my question now.
Okay, fair enough.
Actually, this is for all panellists, if you have thoughts, but particularly James and Dr. Tiwasin or Tanarak, about travel and the new ideas being discussed, particularly in Australia now and also the region, about travel bubbles. Thailand is also thinking of travel bubbles when travel recommences. Two things. One is Thailand, I see in recent days the infected people here are coming in from Thais coming back from particularly Middle East, and they are going straight into quarantine. But in fact, they're coming in on planes that are full. So I wanted to know, is everyone who's on a plane unfortunate enough to have infected people on it also being treated in the same way, going straight into quarantine? And secondly, could perhaps, James, you could talk about the travel bubble concept in the context of what we're seeing in Australia and in relation to Thailand, and perhaps any other panellist.
Why don't I start just by talking about the travel bubble?
That's a good idea.
As you probably know, New Zealand has basically returned to normal, I think yesterday or today, because they went 17 days without any community transmission. Australia is sort of heading in that direction, but still got some way to go. I think today we might have had our first day without any community transmission, but New Zealand went for 17 days without community transmission. So once we can get ourselves to that same level as New Zealand, I think people will start to look much more seriously at making this bubble work. Because already between Australia and New Zealand, there's a trans-Tasman sort of travel arrangement where we don't need visas for each other's countries. We do have to have a passport. We don't have visa-free travel. So it's a very easy thing to do. But while in Australia there's a cautious sort of approach to this, the New Zealanders I think are much more pressing much stronger on it. They gain more from the tourism flows than we do, but they're also far ahead of where we are on this local transmission. But it will happen, but I think it'll take a couple more months yet.
Right, Dr. Tanner.
Let me try to understand your first. I think you have two questions, right? What would happen if there is a case infected on the plane and then arrive at the airport? The first question, we have our routine of doing the screening at the airport. If we identify anybody who has fever at the airport after they arrive from the planes, then we are going to investigate, and we would like to identify anybody who come into close contact to those persons on the planes. And our strategy was trying to identify the person who sit on the same rows and 2 rows before and 2 rows behind, and identify them and check them if they have come infected later. But the fact that everybody's on the plane has been put into the quarantine system, then it's very easy to track them and then look after them if they have any symptoms or not. Those are the things that we have done from investigation of any kind of dangerous pathogens, starting from MERS. If you remember, about a few years back when we have first case of MERS, and we detect them very early, and then we do investigation to track down the passengers. It's the same procedures that we are still doing it, and I think it's the standard that every country is doing investigation and contact tracing that way. About your second questions, I think what we are considering at the moment is we trying to draw up the plan about bringing in the tourists. And the ways that we look at it is that we are trying to start the same ways. We start from low risk first, and then probably later on, after we test the system, then we can open up it wider and broader. So what I can say is that at the moment we are considering how to open the countries for the tourists so that it should be safe for our countries that at the moment we have. I would say that if we don't, I'm going to say that we may have very limited local transmission at the moment, and we would like to keep it that way. But it doesn't mean that we are not going to open up. It means that we will, and then we will consider the ways to make it as safe as possible, and starting from the very low risk approach up the levels as the same way as we open up our country at the moment.
Right, Jonathan, you got some Facebook questions.
Yes, I have one of my own first, and I've got a couple of Facebook questions too, if that's all right. My question, not surprisingly, to Dr. Tanarak. You will remember, Dr. Tanarak, I came to see you up at the Department of Health, I think in February, to ask at that stage about Thailand and why numbers weren't taking off. And I remember you referring me to a case in Pathum Thani of a woman that you said should have been a super spreader, but wasn't. And you were very surprised, that hadn't led to much more rapid infections. Do you have any idea yet why we haven't seen, apart from the boxing ring and the bar in Tonglaw, the kind of super spreader events that we've seen in Europe and the United States? When everyone accepts that Thailand's taken some very, very effective measures, and yet nowhere in Southeast Asia have we seen an incredible eruption of cases the way that we have in Europe and the United States. It's just on a completely different scale. Do we have any idea of the reasons for that?
Would you like Dr. Anutin to...
That's a very difficult question. We actually, I would like to put it this way. We have several events, not just the one that you mentioned. We have another event that we have a student coming back from affected countries, arrived in Bangkok, stay in Bangkok with their family for a few days, and then later on took on the coach, the air-conditioned bus, and traveled for more than 10 hours to arrive at his hometown. And then after that, he still spent a few days in the communities, going around, and end up in the hospital and was diagnosed with COVID-19. And we did investigation of close contact in Bangkok. On the bus, we identified everybody on the bus and test them and quarantine them for 14 days. And also the community community in his hometown. Again, those events that scare me quite a bit. It doesn't turn out that anybody was infected by that patients. On the opposite side, if you look at how easily the disease spread from certain situation where people did really have a very low contact time, and if you look at them, you may not think that is not a high risk contact, but it turned out to be that those were tested positive, like the situation in boxing arena. That have so many people infected on the same days, and so many were infected at that time. So I actually don't have explanation for that. But if you look at our ways that we do our data from our investigation, that one of my explanation is that probably a mild case may not spread the disease as effectively as the one who has more severe symptoms of, let's say for example, the cases that I mentioned that have very low risk and have a lot of contact, a lot of close contact. Actually, his symptom was very mild. He doesn't cough that much. He doesn't During the time that when he was in Bangkok, his relative say something like, if not being know that he have symptoms from starting from before he traveled, they never know that he was a case. So that is probably one explanation, but others, for the one who has really severe symptoms but did not really transmit the disease, I actually don't have explanation for those.
There was actually a related question from one of our club members, Karen Emmons, who's asking about the number of people in Thailand in January who'd come from Wuhan.
No, we covered it.
Oh, we had that already.
Done,
Okay.
yeah.
There was one other question from. Have you asked one from Paul Risley yet? Okay, Paul Risley is a board member. He's asked when there may be a blood test for antibodies. He was saying that he wondered whether he'd had it. He thinks he may have had COVID-19. He had some symptoms in February. So he's asking when in Thailand there might be an effective antibody test available that will tell him and others whether they actually had COVID-19.
That is very easy question. I'm going to answer that. Actually, several universities has that test right now. If you remember Dr. Supaporn, one of your guests, you can approach her, and she did have the testing for antibodies. And other universities also develop those tests as well. Our Department of Medical Science can also do the testing. But these are the testing that they develop. Some of them developed by themselves, and some of the institutions like Chulalongkorn University, they use the testing that was developed by Singapore. So
it does exist now. There is an antibody test if you want to.
Right. Yes, of course.
Panu?
I'm Panu from Reuters and also a board member. I have three questions to Dr. Thanarak and to Mr. Tavisin from my colleague from Japanese press. The first question, I'll speak in Thai and English. The first question is about reports in the Thai media yesterday saying that the health ministry has ordered all government hospitals to check all patients who are admitted to hospital for COVID-19. Is there a truth to that? And would that be expanded to private hospital as well? อันนี้ถามเรื่องจดหมายของปลัดสาธารณสุขเมื่อวันที่5 มิยอนนะครับที่บอกว่าจะให้ตรวจโควิดคนไข้ที่แอดมิดทั้งหมดในโรงพยาบาลรัฐแล้วถ้าจริงแล้วโรงพยาบาลเอกชนจะขยายไปด้วยไหมครับ Second question.
Panu, let's just do them one at a time.
Okay, sure.
You've got the mic. Okay, it's the first one.
พอเห็นคำถามเป็นภาษาไทยจะตอบเป็นภาษาไทยอยู่เลยนะครับ Actually, the Permanent Secretary did really sign those letters, but at the moment we are reconsider of are we going to go as planned or not. So it's just a letters that kind of not an orders, but it's a recommendation for the hospital to consider doing it, and also that we are thinking of how to do it properly, and probably adjust some wording that is not really clear on the letters.
On that note, going forward beyond the present emergency situation, when Thailand reopens again, my colleague raised concern that I know that the government would encourage people to have more COVID tests in the future, but would the government still cover the cost of these tests when Thailand opens up, when there are foreign travelers coming in? I mean, what's the arrangement would be going forward?
ถามภาษาไทยได้ไหมครับ
ได้ครับก็เขาถามว่าเนี่ยพอประเทศจะเริ่มเปิดมองไปในอนาคตข้างหน้าเนี่ยครับมันยังมีคอนเซิร์นไหมเกี่ยวกับการตรวจโควิดที่เหมือนกับว่าทางฝั่งรัฐเองคง encourage ให้คนมาตรวจเยอะขึ้นโดยเฉพาะยิ่งคอนเซิร์นเรื่อง cost นะครับว่าถ้าเกิดหลังจากเนี้ยไป 2-3 เดือนข้างหน้าเนี่ยครับคิดว่าทางรัฐเองยังจะอุ้มเรื่อง cost การตรวจอยู่ไหมหรือว่าต้องแล้วแต่ arrangement ของ traveler ที่เข้ามาในไทยหรืออะไรก็แล้วแต่ทั้งคนไทยและคนต่างประเทศนะครับ
หมายถึงเทส
โควิดทั่วไปครับถ้าเกิดเรา
เทสคนไทยที่ติดเชื้อหรือยังไงผมไม่แน่ใจ
เข้ามาหรือว่าอะไรอย่างเงี้ยครับหรือต้องเดินทางออกไปที่อื่นอะไรอย่างเงี้ย
ผม ผมไม่แน่ใจว่าผมเข้าใจคำถามตรงไหมนะ I put it this way. At the moment, most of the COVID testing cover with our 30 baht health scheme. So National Health Security Office cover those testing. And according to the laws, if you are Thai citizens and if you have reasons as recommended by the Ministry of Public Health that you need testing, then all the costs will be covered by Thai government. Now, for the international travelers that will come in, we request the travelers to also have. At the moment, actually, the rules is still in. I mean, we are still using that. Is that we request that all the travelers who come in from other countries into Thailand, they need to have health insurance of at least 100,000 US dollars of coverage. So, I think if it is recommended that those need to be tested by any reasons, as the Ministry of Public Health will put on, then I believe that those testing will be charged upon the health insurance scheme that they have.
Last question that my colleague has is, as of this morning, there are about 90 people left being treated in hospital, according to the daily press. Are these people all Thai nationals, and are there any critical cases left?เมื่อเช้าตามที่ตัวเลขบอกว่ายังมีคนในโรงพยาบาลประมาณ90กว่าคนนะครับเป็นคนไทยทั้งหมดหรือเปล่าแล้วก็มีเคสที่เป็น critical ที่สาหัสที่ serious เหลืออยู่บ้างไหมครับ
critical ตอนนี้เราไม่ได้อัปเดตเคสที่หนักนะครับแต่เท่าที่รับฟังถ้ารีวิวกันสักประมาณอาทิตย์ก่อนหรือ2อาทิตย์ที่แล้วเนี่ยเหลือหลักหน่วยก็คือ 1-2 รายไม่น่าจะเกิน5รายที่เป็นรายที่หนักนะครับเพราะนั้นณตอนนี้ก็รายที่หนักเนี่ยเท่ากับหลักหน่วยมากกว่านั้นรายที่อยู่เนี่ยยังไม่มีรายงานที่เป็นอย่างนั้นนะครับครับ
แล้วส่วนใหญ่เป็นคนไทยใช่ไหมครับไทยนะ
ครับส่วนใหญ่คนไทยแล้วตอนนี้ครับ
ขอบคุณครับ
The majority are Thai nationals, and in terms of critical cases, because the situation has been relatively alleviated, the updates have been less frequent. But as of last week, there are 1 to 2 critical cases, which means that currently there will probably be under 5 critical cases.
Great. Jonathan?
Yeah, I'm just looking at other questions coming in. This one's from Martin Bensky-Stalling, who's a club member. He's asking, why does Thailand still have domestic travel restrictions, particularly for foreigners, he says, who travel to Chiang Mai from Bangkok, who have to face, I think, 14 days of self-quarantine. I actually think that quarantine applies to everyone, not just foreigners, although some foreigners have that impression.
Who travel by air?
If you travel by air, yes.
Because otherwise...
Just a question as to why those restrictions still exist.
After the last open on June 3rd, I believe that we already lift all the restriction, all the domestic restriction. So if you arrived in Thailand more than 14 days, I mean, if the foreigners arrived in Thailand for more than 14 days, they can travel all around the countries the same as Thai.
Are there, because I understood those restrictions were decided by local provincial governments, and that they seem to vary quite a lot. I mean, Chiang Mai seem to have quite strict ones. Is it now decided centrally, or can provinces still decide for themselves whether they need to impose restrictions? I mean, we've seen what Phuket has done as well.
I believe that CCSA already have a written recommendation or have a written orders on the already is on June 3rd, and I believe that still, if let's say if provinces, this is in theory, but I believe that most of the provinces already lift their travel restriction after June 3rd. But let's say if there is any governors or would like to still impose those travel restriction if he or she has power to do so, the answer would be yes. But I don't see any reason to do that, and I believe that most of the provinces will lift those travel restrictions already.
There was just one other question, actually from Mike Tivayanon, who's from the Prime Minister's office, who's asked whether, looking at what New Zealand has done, New Zealand has been very successful and now effectively says COVID-19 is over inside the country, but has made a decision not to open its borders to overseas travel yet or for the foreseeable future. And he's asking, is that a model Thailand should follow? That, however successful we are here in Thailand, that you should wait a very long time before opening up your borders at all, like New Zealand?
Okay. I think what we are doing at the moment, what we are doing and what Ministry of Public Health is thinking to recommend CCSA to do is that we would like to have our countries to come into, to put our countries back to normal as much as we can first, and then we would start open up our border later. But there is one thought was that if we are in these situations long enough, and then there are needed for business persons who would like to come in and not just for travel, but he has business reason to come in and work in Thailand. We know that at the moment there are a lot of international company staffs who now have to come in shift or have to come in and do business in the countries that are waiting for the country to open up. We start a conversation and trying to discuss about this, and very soon I believe that we are going to open up first to the business person who want to come in, and this is very low risk approach, because we already mentioned about, because they are going to stay in Thailand for quite a long time, so they can still follow the same rules of coming in, having quarantine for 14 days, and the travel cost and the quarantine cost would be paid by who, and then he can come in and join their companies and work in their companies. Those are the conversations that we start to have with the international companies, and probably when the time's right, I believe that we will start with that first before we open it up for all the tourists.
Yeah, I've got other questions relating to alcohol, but I think you might have
got one behind
answered
you, so let him have a go.
My question is for Dr. Tanarak as well.
Into the microphone, please. Speak.
Dr. Tanarak. Okay, yeah. My question is about, you talked a lot about universal precaution and HIV and how it relates. And we know that in South Korea, for example, when they enabled or brought about anonymous testing, that there was a surge in the number of people being tested for COVID-19 because it lowered the risk for the person that was getting tested. And I wonder if that's something that is on the table in Thailand, because we know we've talked about the cost, we've talked about when it's administered, but what we haven't talked about is what comes along with getting the test. And whether or not anonymous testing is on the table is an important comparison to really make if you're talking about treating this similarly to how we were treating HIV. Because right now, anonymous testing is available for HIV, and it's free. So I'm wondering if anonymous testing is something...
Free anonymous testing is an option in Thailand.
It is not.
No, he'll answer. I don't know.
Okay.
Can you repeat the question again?
Sorry, so the question was, is there the possibility of free anonymous testing for COVID-19 in Thailand, as there has been with HIV, AIDS in the past? And anonymous, so people don't have to say who they are. This is a big issue even.
This happened in Seoul as well. There was a surge in people getting tested for COVID-19 once they made the anonymous test available.
Actually, we haven't considered about doing anonymous testing. I think there is a lot of difference between COVID-19 and HIV. HIV for COVID-19, if you tested positive, there are so many implications or or things that you need to do in order to prevent others from getting infection from you. HIV also as well, but for COVID-19, since the symptom is very short, if you have mild symptoms, usually after 14 days, you are not going to spread the disease to others. That is in general, and if you have very severe symptoms, it will show up within the second weeks generally, and then you need hospitalized and have treatment very quickly. At the moment, our strategy is to try to lower the case fatality rates or mortalities, as you know, is that we would like to admit every single patient, no matter he or she has symptoms or not. So that is probably why we are not considering anonymous testing, because if you are testing positive, you are going to be admitted to the hospital anyways. I'm not sure.
Okay, we're running very late now. James, I don't want you to, it's very late for you, but can I just bring you in? Do you have one specific recommendation or something that you would like to see in Thailand that you think would help with this situation? We had a little chat about it earlier.
No, it's not so much a recommendation as just a question I have. Well, first of all, let me say my sense from media reports is these very successful village health volunteers are overwhelmingly women. Probably, I think, and I read one article somewhere, I think maybe 60 to 70% of them may be. And it set me thinking about this because, of course, women tend to, because of their roles as mothers, have a stronger sense than men do of health issues, sanitation issues, and a stronger sense of community. And I think there's a case to be made that they're probably better managers in many ways than men are. Was wondering whether there's been any discussion in Thailand about this question. And I recall that a former deputy governor of BMA, Dr. Pusadi, who is, not on the red side of politics at all, quite the reverse, a stalwart of the Democrat Party and I think heavily involved in PAD. She had a suggestion some years ago to try to make it easier for women to get into politics in Thailand, that they have a quota that 50% of all elected representatives in community government, local government, should be women. So I'm just wondering whether with this wonderful story with the health volunteers, whether my observations about the proportion of women are accurate, and if so, whether there's any discussion at all about a greater role for women in the administration and ultimately in the politics of Thailand.
So, the ambassador is recommending greater participation of women in the volunteer health organisation and other aspects of Thailand. Is this something that's discussed inside the Thai medical hierarchy? More women workers?
ก็ถ้าพูดถึงบทบาทของผู้หญิงต่อเรื่องของสุขภาพถ้าพูดถึงด้านนี้มันก็มีมานานแล้วของคนไทยนะครับแล้วก็ผมก็ว่าก็เป็นลักษณะของ culture ของคนไทยแหละครับที่เป็นห่วงเป็นใยเป็นแม่บ้านที่ต้องดูแลพวกนี้แล้วก็ถ้าจะภาพที่จะเห็นภาพชัดก็คืออยู่ในอสม.ซึ่งเป็น health volunteer ที่อยู่ในพื้นที่เนี่ยโดยส่วนใหญ่ก็เป็นผู้หญิงแต่ถามว่ามีผู้ชายไหมก็มีนะครับดังนั้นบทบาทด้านนี้ถามว่ามันก็เป็นบทบาทที่ถามว่ามันก็ถามว่าเป็นที่คุ้นเคยแต่ว่าเพิ่มขึ้นไหมก็ในเมื่อมันเป็นมาก่อนหน้านี้อยู่พอสมควรอยู่แล้วก็อาจจะไม่ได้ดูว่ามันมีความแตกต่างนะครับถ้าจะถาม
If we're talking about the role of women in terms of public health in Thailand, then we can say that there's an existing culture of women already having a very prominent role. For instance, traditionally, women were responsible for the healthcare of their household, and women represent a huge percentage of the over 1 million healthcare volunteers that we were discussing. So there's already great familiarity with women being involved in public health. since there's a pre-existing culture of female participation, there isn't such a great divergence between male and female representation in public health in Thailand today.
Great. All right, one last question because we've run to the deadline, to the limit. Dr. Tabasin, Thailand has had this very, very strict regulation on alcohol. And that's obviously a huge consideration for the hospitality industry, but it's also quite unusual. And you gave a fairly detailed explanation of why, in Thailand's case, that was an important thing to do. And maybe you could explain that, because I don't think it's widely understood internationally. And of course, there's also great interest from Jonathan Head to know when it's going to be lifted.
ครับก็ถ้าพูดถึงเรื่องของแอลกอฮอล์กับคนไทยก็มันเป็นสาเหตุของการสูญเสียทั้งชีวิตแล้วก็เรื่องของการเจ็บป่วยที่ชัดเจนนะครับมีการรีพอร์ตเรื่องของปัญหาทางด้านเรื่องของแอลกอฮอล์ดิเพนเดนซ์หรือแอลกอฮอล์แอบยูสขึ้นมาเนี่ยในผู้ชายคนไทยถึง 30% ที่เคยมีรีพอร์ตจากทางกรมสุขภาพจิตนะครับแล้วมันก็ยังเป็นตัวที่รีเลทไปกับเรื่องของอุบัติเหตุเรื่องของการบาดเจ็บและเสียชีวิตอื่นๆอีกมากมายแล้วรวมถึงเรื่องของ abuse physical abuse ที่อยู่ในเขาเรียกอะไร domestic violence ต่างๆที่เชื่อมโยงไปอีกหลายอย่างนะในคนไทยอันนี้คือด้านสุขภาพนะครับทางด้านศีลธรรมเนี่ยทางด้านคนไทยโดยส่วนใหญ่ 90% ก็นับถือศาสนาพุทธและหนึ่งในศีล5ข้อก็เป็นเรื่องของทางการงดเรื่องของสุราเป็นข้อที่5ซึ่งก็เป็นเรื่องที่สำคัญเพราะฉะนั้นในช่วงระยะเวลาประมาณสัก10 ปีให้หลังมานี้ก็มีการรณรงค์เรื่องนี้กันอย่างมากมายนะครับผ่านทางสสสซึ่งเป็นองค์กรรณรงค์เรื่องของบุหรี่แล้วก็มาทำเรื่องเหล้าด้วยนะครับนั้นพอมันมีทั้งเหตุมีทั้งปัจจัยรวมกับทางด้านศาสนาแต่อย่างไรก็ตามแต่นะครับมันก็มีลักษณะ culture เรื่องของการดื่มก็เป็น culture ที่เป็นสาเหตุก็คือเป็น culture ของคนทั้งต้องเรียกว่าไม่ใช่แค่ไทยเอเชียทั้งหมดก็เรื่องของการดื่มสุราซึ่งมีบางคนที่ไม่สามารถหักห้ามใจได้อย่างที่ว่าแล้วก็เกิดเป็นแอลกอฮอลิซึมอะไรทั้งหลายก็มีจำนวนมากนะครับเพราะฉะนั้นเมื่อมีคนที่ดื่มเยอะก็ต้องมีอีกฝ่ายหนึ่งที่จะต้องบาลานซ์กันเพราะฉะนั้นตรงนี้แล้วเข้ากับ culture เข้ากับบริบทนี้ทางภาคของรัฐก็มาtake role หรือมารับผิดชอบด้านนี้มากขึ้นแล้วก็หลังๆก็จะมีโปรแกรมในเรื่องของการบำบัดสุราที่ผ่านมาจากกรมสุขภาพจิตอีกหลายโปรแกรมนะครับที่ร่วมมือกันทั้งในภาคประชาสังคมภาคอะไรทั้งหลายโดยเฉพาะที่เราเห็นปัญหามากๆก็คือทางภาคเหนือของประเทศไทยซึ่งก็ตอนนี้ก็ดำเนินการไปอยู่นะครับแล้วก็บางส่วนบางที่ก็ได้ผลแต่บางส่วนบางที่ก็ยังต้องรณรงค์กันต่อครับ
So when we talk about alcohol actually has quite a significant presence in Thai society. It has often been the cause of fatalities and serious illnesses. The rate of alcohol dependence and alcohol abuse has increased, and in certain communities it's reported at 30% of males. Therefore, we've had various programs from the Department of Psychiatry that emphasizes the dangers of overdependence on alcohol, which has been the cause of road accidents, which is something that's well known, as well as other types of violent incidents like physical abuse and domestic abuse. And of course, we also have a temperance lobby in our country as well, since over 90% of our country are Buddhists, and they adhere to the 5 precepts, the 5th precept being abstention from alcohol. So we can say that there is both a necessity in terms of the serious impacts of alcohol abuse, and we can also say that there's an impetus in terms of certain public health campaigns from the public themselves, including associations that campaign against overdependence on alcohol and nicotine. And so this culture of drinking, however, I have to emphasize, is not just particular to Thailand, but it is an Asian-wide culture. And the higher rates of alcoholism now in our country are very concerning. So what the CCSA has been attempting to do is acting as a counterbalancing force to ensure that alcoholism does not escalate the problem with the spread of COVID-19. Other than that, we have pre-existing programs to promote moderate drinking and to fight against alcohol addiction. This is particularly strong in the north of the country where there is an alcoholism problem, and in certain areas it has proven very effective, in other areas less so.
มีเสริมอีกนิดหนึ่งที่เห็นได้ชัดตอนที่โควิด -19 ในช่วงที่เรามีคำสั่งห้ามดื่มเหล้าในช่วงของเทศกาลสงกรานต์ที่ผ่านมานับเป็นครั้งแรกของประเทศไทยที่สั่งห้ามกันได้ทั้งเข้าใจว่าน่าจะ76 จังหวัดบวกกทม.และผลของการที่สั่งห้ามขายสุรานี้ทำให้ถ้าผมจำไม่ผิดนะตัวเลขของการเสียชีวิตเนี่ยลดลงไปเหลือ1 ใน 3ของปีที่ผ่านมาเท่าที่จำได้อันนี้ข้อมูลอาจจะผิดพลาด
And an additional important statistic is that amidst this COVID-19 crisis, during the Songkran festival, which has traditionally been a time when people drink a lot, the ban on the sale of alcohol, which is the first of such a ban in all 76 provinces of Thailand and the Bangkok metropolitan area, has resulted in a decline of fatalities during the period being a third of what they used to be, which is a pretty remarkable figure.
Which is a very interesting. Is there a date for lifting it? The date.
ก็เดี๋ยวรอลุ้นอาทิตย์นี้ฮะผมเองก็อยากจะได้เหมือนกัน
We have to see the developments this week. I myself am looking forward to the time when
เรื่องนี้ทำให้เสียเวลาอยู่นานนะนี่กว่าจะออกมา
Well, look, that's been a very interesting talk. The idea that Thailand is actually net positive in terms of people alive at the end of the COVID-19 thing is something that Craig will look into in the future and evaluate. We haven't discussed a number of things. We haven't discussed the silent epidemic, how it's affected people's health and things that are actually undetectable at this point. But I think we've given a good pointer to where things have gone in the right direction. So I'd like to thank Dr. Tawisid for coming to see us, Dr. Tanarak for coming yet again, and I hope you'll both come back. Craig Griffin for his insights on figures, Matthew for his insights on coverage, and of course James for staying awake in Australia. It's great to see you. You're looking good. We like the beard. And also I'd like to thank our wonderful translator who slipped in here without giving me his name. Just say it, Michael. Pongset. Well, excellent translation. And thank you, Julian Haddon, for the technical wizardry. Thank you.